Hello, everybody. I'm Dan Limbach, producer of the Pharma Voice Webcast Network, and I will be your moderator today. Welcome to our event entitled Understanding the Interplay Between Medicaid and 340B, brought to you by Pharma Voice in partnership with our good friends at Manat Health. We really have an outstanding crowd today with executives from across the industry. This has quickly become one of our most popular webinars of the year, so thank you for investing the time to attend. We will certainly do our very best to make it worth your while. Before we get started, I just want to cover a few features of our webinar technology. Your GoToWebinar control panel will give you access to several functions. If you can hear me but are experiencing problems logging in to see the slides, you may want to try logging in using a different browser, and we recommend the latest versions of Internet Explorer, Firefox, and Chrome. Tablets and smartphones also work if you have the free GoToMeeting mobile app. For any other issues, you can use the robust help options from your control panel, or you can go to gotowebinar.com, and you can even send us a message using the questions function in the control panel, and we'll do our best to help you out. You're going to be able to download a PDF of the slides as well as the CLE attorney affirmation document using the handouts area of your control panel. And if you have any problems with that, you can also send us a question. We're taking questions from the audience today, and you can participate in the Q&A session by asking questions at any time during the presentation. Just type your question into the questions text area in your control panel and click the send button. We'll also have a couple audience polls during the presentation, so get ready to participate with those. At the conclusion of the webinar, you will see a survey which you'll be able to share your feedback so we can make our future webinars even better. And that's also going to be used for the CLE. So you're going to be seeing and hearing a great deal of useful information today, and you don't have to memorize everything during this live event or take copious notes, because we are recording this and we will send you a link to the on-demand archive in a day or two so you can review the event at your leisure. Now that we're through with the housekeeping details, let's dive into the program. We have a very knowledgeable expert with us today to help us understand the complexities of 340B and how it works with Medicaid. We'll also explore the results of Manat's 50-state study on this topic. With that, we're happy to welcome Helen Pfister, partner at Manat Health. Based on the outstanding turnout today, our topic is clearly an area of interest, and it promises to be an extremely informative session. I know I'm looking forward to it. So Helen's going to start things off with an informative presentation. Immediately after that, we'll have some Q&A time to address questions submitted by the audience. So Helen, take it away.
Great, thanks. Thank you for the introduction, Dan, and good afternoon, everybody. My name is Helen Pfister, and I am a partner in the New York City office of Manat Health. And I'm here to talk about the interplay between the 340B prescription drug discount program and the Medicaid program. And just for a little bit of context, I've been working on 340B issues since the late 1990s, when the 340B program was a pretty small and obscure federal program that not a lot of people paid a lot of attention to. And over the course of the past 2 decades, I've sort of watched it evolve into what it is today, and it's certainly been a very interesting ride. So I'm going to start with providing some background on both the 340B program and the Medicaid drug rebate program, just so that everyone on this webinar is on the same page. And then I'm going to focus on the interplay between the 340B program and the Medicaid program, including particularly the challenges inherent in ensuring that a drug isn't subject to both a 340B discount and a Medicaid rebate. I'll then discuss the survey that Dan referenced, which Manat conducted, of Medicaid and 340B policies across all 50 states, which focused on 2 things. One is what states are doing to ensure that a drug isn't subject to both a Medicaid rebate and a 340B discount, and also how state Medicaid programs reimburse for both 340B and non-340B drugs. And then I'll spend a few minutes in the looking forward section here, like what's next for 340B. But before that, just to kind of get a sense for who the attendees on this webinar are, I'm going to ask you to respond to a quick poll, which asks which of the categories on this slide best describes the organization that you represent.
So you've got 5 choices here: pharmaceutical manufacturer, hospital or other 340B covered entity, healthcare payer, pharmacy, or other. And like Helen said, this gives us a good idea of who's in the room now, and that's always valuable to know. So we're getting really good participation in this. It's still going up. We'll give everyone one more moment. Okay, great. Let's say last call, and I'm going to close this and share the results with everybody. So it's a pretty good spread across the board, Helen. Is this the kind of group you were hoping to see today?
Yeah, it is actually. Obviously curious about who the other are. I guess maybe we should have put in more categories, but it's certainly a good balance of stakeholders in this area. So helpful and interesting to see.
Great. Let me put this away, and you can continue.
Okay. So the 340B program has been around for close to 30 years. It was established by statute back in 1992. And basically what it does is require pharmaceutical manufacturers that participate in Medicaid, which is basically virtually all pharmaceutical manufacturers in the United States, to provide discounts on outpatient drugs to certain healthcare providers and healthcare programs that are actually set forth in the statute. It applies, like I said, to outpatient drugs and specifically to the categories of outpatient drugs set forth on the bottom of the slide. So it's FDA-approved prescription drugs. It is over-the-counter drugs written on a prescription, biological products dispensed only by prescription, and FDA-approved insulin. The program is overseen by the Federal Office of Pharmacy Affairs, which is within the Health Resources and Services Administration, or HRSA, within the U.S. Department of Health and Human Services. Initially, when the 340B statute was enacted back in 1992, there were 9 different types of providers and programs that were eligible to participate, and those are the ones listed on the left side of this slide. It included hospitals with a certain disproportionate share percentage, meaning which was representative of the Medicare and Medicaid patient populations that those hospitals serve, federally qualified health centers, and a variety of other recipients of federal grant funding, including Title X family planning clinics and recipients of Ryan White program funding. And then in 2010, the Affordable Care Act added 5 more categories of eligible entities, which are listed on the right side of the slide. And for anyone who's not super well versed in 340B lingo, entities that participate in 340B are usually referred to as 340B covered entities or just covered entities. So when I use those words, that's what I'm referring to. One of the key limiting elements of the 340B program is that only individuals who qualify as patients of a covered entity under a patient definition that was promulgated by HRSA are eligible for 340B drugs. That definition was established by HRSA, or the Office of Pharmacy Affairs within HRSA, through a Federal Register notice back in 1996. And as you can see from the slide, individuals who meet the 3 bullet points set forth on here qualify as patients of a covered entity for 340B purposes. So the covered entity has to maintain records of the healthcare that the individual received, the healthcare that led to the dispensing or administration of a drug. The clinician who provided that healthcare has to either be employed by the covered entity or provide the services under another arrangement so that responsibility for the care stays with the covered entity. And if the covered entity isn't a hospital, then the healthcare services in question have to be services for which that covered entity got the federal grant funding that made it 340B eligible in the first place. The other element of that definition is that an individual will not qualify as a patient of a covered entity if the only healthcare services the person receives is the dispensing of drugs that the person will subsequently self-administer or that will be administered to the patient at home. The 340B patient definition has been subject to a fair amount of criticism since it was promulgated in 1996 for being too broad or too vague. And back in a few years ago, the Office of Pharmacy Affairs actually released proposed 340B program guidance that would have narrowed the definition significantly. That guidance ultimately was not adopted, So the 1996 definition remains in effect. But it's certainly, anyone who's spent any time with the 340B program knows it's definitely an area of much discussion, for lack of a better word. So since this webinar is about the interplay between 340B and Medicaid, the next thing I'm going to do is spend a few minutes on the Medicaid drug rebate program. The Medicaid rebate program dates back to 1990. And what it does, what it's intended to do, is ensure that generally state Medicaid programs get prices for drugs that are consistent with the best price at which manufacturers sell those drugs. And currently, all 50 states plus the District of Columbia offer prescription drug coverage as part of their Medicaid benefit design. Manufacturers that want states to be able to use federal funding for their products, so basically all manufacturers essentially, have to enter into a national drug rebate agreement under which they agree to pay rebates to states for drugs that are paid for by the Medicaid program. And then in exchange for receiving those rebates, the state Medicaid programs have to, with some exceptions, cover all the manufacturer's drugs when those drugs are prescribed for a medically accepted indication. Some state Medicaid programs also negotiate supplemental rebate agreements with drug manufacturers to further reduce Medicaid expenditures, but that's something I'm not really going to touch upon. It's that's beyond the scope of this webinar, but just wanted to reference that for those who are interested in this space. So the next slide provides some high-level details on how the Medicaid rebate program works. Rebates are based on the average price paid to the manufacturer for the drug in the U.S. By wholesalers for drugs that are distributed to retail community pharmacies, and by the pharmacies themselves if they purchase drugs directly from manufacturers. CMS then calculates a unit rebate amount for each Medicaid-covered drug, which is a percentage of the average manufacturer price, or AMP. And then state Medicaid programs multiply that unit rebate amount by the number of units of a drug that were dispensed to Medicaid patients, and then that's the rebate that the manufacturers owe to the state. Again, this is very high level, and there are a lot of nuances and concepts that aren't addressed here, but I think for purposes of this webinar, this should be sufficient detail. Okay, so 340B and Medicaid. The most important principle when it comes to the 340B program and Medicaid, which I mentioned earlier, is that a drug can't be subject to both a 340B discount and a Medicaid rebate. That would result in a duplicate discount. And that's actually a statutory requirement that was included in the 340B program statute when it was enacted back in 1992. So basically, that means that there are two options to ensure that duplicate discounts don't occur. Option one would be that the 340B covered entity, hospital, FQHC, whatever it is, doesn't use 340B drugs for its Medicaid patients. It can use 340B drugs for uninsured patients or commercially insured patients or Medicare patients, but it doesn't use them for Medicaid patients. And that way, the state Medicaid program can request rebate for drugs, and there's no risk of a duplicate discount. Option two is that the 340B covered entity does use 340B drugs for Medicaid patients, but then the state Medicaid program has to ensure that it can exclude those drugs from its Medicaid rebate request. And what that means is there's got to be a way for the state Medicaid program to know that a 340B covered entity used 340B drugs for Medicaid patients, so that the state doesn't turn around and then request rebates from the manufacturers for those drugs. And under this option two, since the state Medicaid program is now essentially foregoing Medicaid drug rebates, covered entities are required to bill Medicaid for 340B drugs at their actual 340B acquisition cost. So that way, instead of getting the rebate, the state Medicaid program is getting the benefit of 340B 340B pricing. And before I go into any more detail about that, it is 3:15. So I'm going to read the first of two CLE codes. It is KUE 896. That's Kilo Uniform Echo 896. So methodologies for state Medicaid agencies to identify 340B drugs and exclude them from the rebate request. There are basically two ways to accomplish this. The Office of Pharmacy Affairs maintains a Medicaid exclusion file, which lists all covered entities that use drugs for Medicaid patients on the fee-for-service side. So that way, in theory, a state Medicaid agency can look at the Medicaid exclusion file, can identify the covered entities in its state that use 340B drugs for their Medicaid patients, and can exclude drug claims from those covered entities from the Medicaid agency's rebate request to drug manufacturers. The other option is identifying 340B drugs at the claims level. So under a claims level approach, 340B covered entities use a specific modifier or identifier on each claim they submit to the Medicaid program for a drug that was purchased under 340B. And in theory, the Medicaid program can use that data, exclude those drug claims from its rebate request, and ensure that there is no duplicate discount. Neither approach is perfect. There have always been concerns about the accuracy of the Medicaid exclusion file. In some cases, covered entities aren't as diligent as perhaps they could be in keeping it updated. And as for claims level identifiers, they only work if covered entities use them whenever appropriate, and if the state has a mechanism for ensuring that it is able to carve claims tagged with those identifiers out of its rebate request. But when it comes to 340B and Medicaid fee-for-service, it's a little more straightforward than other areas. Medicaid managed care is much more complicated. Before 2010, Medicaid managed care wasn't an issue in the 340B context because the Medicaid drug rebate program only applied to drugs paid for by Medicaid on a fee-for-service basis. In other words, states weren't able to request rebates for drugs paid for by Medicaid managed care organizations, and so there was no risk of a duplicate discount. A 340B entity could buy drugs under the 340B program, bill the Medicaid managed care organization, there would be no rebate request, and so no problem. But then in 2010, the Affordable Care Act, in addition to expanding the categories of providers that were eligible to participate in 340B, as I mentioned earlier, also expanded the Medicaid rebate program to cover outpatient drugs paid for by Medicaid managed care organizations. So now, since then, the duplicate discount risk exists on both the Medicaid fee-for-service and the Medicaid managed care side. As I mentioned a minute ago, HRSA does require covered entities that use 340B drugs for Medicaid patients to give HRSA their Medicaid provider numbers or NPIs, and then HRSA lists them on the Medicaid exclusion file. But the Medicaid exclusion file is only intended to address Medicaid fee-for-service. It's not intended to list covered entities that will use 340B drugs to manage care patients, although our 50-state survey does suggest that some states are using it for that purpose anyway. Some states that use the Medicaid exclusion file on the managed care side have managed to address any potential concerns that this would create by requiring covered entities that use 340B drugs for fee-for-service patients to also use them for managed care patients. So that means that they can look at the Medicaid exclusion file. If a covered entity is listed, the state knows that the covered entity is using 340B drugs for both Medicaid fee-for-service and Medicaid managed care patients, and can carve the claims from that covered entity out of its rebate request. But based on the findings of our 50-state survey, it does seem that some states may be relying on the exclusion file to identify covered entities that use 340B drugs to manage care patients without requiring that they use them for both fee-for-service and managed care, and that's potentially a duplicate discount problem. The Medicaid exclusion file is not the only provider-level method of identifying 340B claims. Some states bypass the exclusion file entirely and just require 340B covered entities to notify the state directly as to whether the covered entities are using 340B drugs for Medicaid patients. And that may actually be a more effective approach, assuming that that's sort of clearly communicated and that the covered entities abide by that requirement. So complicating things even further are 340B contract pharmacies. So covered entities can dispense 340B drugs to their outpatients through their in-house pharmacies if they have one. But they can also enter into arrangements with outside pharmacies for those outside pharmacies to dispense 340B drugs to patients of the covered entity. Outside pharmacies meaning a retail pharmacy, a community pharmacy. And the way that works in a contract pharmacy arrangement, the contract pharmacy dispenses drugs to the covered entity eligible patients and collects reimbursement for those drugs. The contract pharmacy keeps a dispensing or administrative fee and then remits the rest of the reimbursement to the covered entity. The covered entity then buys the drug at a 340B price, has it shipped to the contract pharmacy to replenish the drug that the contract pharmacy dispensed to the covered entity patients, so everybody's whole. So the pharmacy dispenses the drug out of non-340B stock, collects payment for the drug, keeps a portion of the payment itself, sends the rest to the covered entity, and then replaces the drug that the contract pharmacy dispensed with a 340B purchased drug. So financially, the bottom line for the contract pharmacy is that it keeps the dispensing fee or administrative fee that is negotiated with the covered entity. And the bottom line for the covered entity is that it keeps the reimbursement, the third-party payer reimbursement for the drug, less the dispensing administrative fee that the pharmacy keeps, and less the cost of the 340B cost of the drug that the covered entity spends when it buys the drug to replenish the pharmacy's stock. So this presents a significant additional layer of challenges from a duplicate discount perspective. So for a state Medicaid program to be able to ensure that a 340B drug that's dispensed by a contract pharmacy under a contract pharmacy arrangement isn't also subject to a Medicaid rebate, there has to be a mechanism for the contract pharmacy or the covered entity or the third-party administrator that they work with to identify claims that were filled using 340B drugs and make the state Medicaid program, Medicaid agency aware of those claims. So they can exclude those claims from the rebate request. But that's not as easy as it sounds necessarily. In many contract pharmacy arrangements, the contract pharmacy, when it dispenses the drug, doesn't know whether or not the drug is being dispensed to an eligible patient, a 340B eligible patient, a covered entity patient. They're just dispensing a drug to someone who comes in with a prescription. Instead, there's a back-end process after the point of sale, after the point of dispensation, where usually a third-party administrator takes data from the contract pharmacy, claims data, and takes data from the covered entity, patient data, prescriber information, reconciles the two, and determines which prescriptions filled by the contract pharmacy are 340B eligible. And so in those types of contract pharmacy arrangement, if the third-party payer is Medicaid, the contract pharmacy can't attach a 340B claim, 340B identifier to the claim it submits to Medicaid, because the contract pharmacy doesn't know at the time it's submitting the claim that the patient is 340B eligible. and that the prescription will ultimately be treated as a 340B prescription. So that's another challenge presented by the interplay of Medicaid and the 340B program. And as you can imagine, all of these issues have just sort of become more challenging and grown in scope as the 340B program has grown in scope, which leads us to our second polling question, which is, how many covered entities do you think were enrolled in the 340B program in 2008? Is
All right,
it
let's
under
put this up.
5,000?
Oh, go ahead, Helen.
I was going to say under 5,000, between 5 and 10,000, more than 10,000, less than 20,000, 20,000 or more, or not sure, have no idea.
So we'll give everybody a moment again. Same drill as last time. Got a lot of responses streaming in. I know what my answer would be, but I'm not going to say. Okay, we'll give everybody just another moment or two. And let's say last call. All right, let's share the results. So the winner was 20,000 or more at 37%. So Helen, you're gonna have to tell, my answer would have been not sure, but you're gonna tell us what the right answer is and maybe talk about these results a little bit.
You're very honest with you, Dan. I appreciate that. So the answer is between 10 and 15,000. As of January 1st, 2018, according to HRSA, there were 12,823 providers registered on HRSA's database, where all eligible providers are registered, as well as just over 29,000 associated sites, child sites. So for a total of 42,000 registered sites. In terms of volume, there is some debate about the dollar amount of 340B sales, and I've seen a real range of different estimates from different sources. I picked this one from HRSA. If you disagree with it, don't blame HRSA, not me. But according to HRSA, back in 2016, total 340B sales were approximately $16 billion, which represented about 3.6% of the U.S. drug market. And then on the contract pharmacy side, according to a 2018 report from the General Accounting Office, in 2017, there were approximately 20,000 contract pharmacies. And I tried to track down, but wasn't able to, what the numbers looked like sort of in the early days of the 340B program. But I'm sure they were significantly smaller. On the contract pharmacy point, there's one thing that I forgot to mention earlier. This seeing 20,000 contract pharmacies reminded me of it. In the earlier days of the 340B program, each covered entity site was limited to one contract pharmacy. So there could only be one contract pharmacy location associated with each covered entity site that was participating in 340B, unless the Office of Pharmacy Affairs specifically approved a demonstration that allowed more contract pharmacies per site. That changed back in 2010, and now covered entities can contract with as many contract pharmacies as they'd like, which led to the 20,000 contract pharmacy number on this slide. So that there are issues with the interplay between Medicaid and 340B is not exactly news, especially when it comes to duplicate discounts. In 2016, the Federal Office of Inspector General conducted a study that focused on how states exclude 340B drugs from Medicaid rebate requests on the Medicaid managed care side. They did some structured interviews with states to look into this, and found that most states use provider level methods like the Medicaid exclusion file. But unsurprisingly, they also found that those methods may not accurately identify all individual 340B drug claims. The OIG did recommend in this report that CMS require states to use claims level identifiers as opposed to provider level identifiers, but CMS declined to do so, saying they didn't have the authority to do that. What CMS did do was inform states about tools that they can use to identify 340B claims, including the identifiers that I was just referring to that some states are requiring 340B covered entities to use. And then more recently, in 2018, in testimony before the U.S. Senate Committee on Health, Education, and Welfare, an OIG official again highlighted what she called the vulnerabilities in 340B program operations and oversight that impede effective operations and oversight. Some of the recommendations aren't directly related to the topic of this webinar, but are of interest to those who follow 340B program issues, such as a recommendation that HRSA clarify the definition of what constitutes an eligible patient for 340B purposes, which, as I said earlier, has been the topic of considerable discussion over the years, as well as a recommendation that HRSA address whether 340B providers should be required to pass 340B discounts through to uninsured patients, which is also a topic that has been a subject of considerable discussion over the years. And discussion in both cases might be a polite term for it. But another area that was identified was a lack of transparency that prevents ensuring that 340B providers aren't overpaying manufacturers for 340B drugs, and also that state Medicaid programs aren't overpaying 340B providers. And again, in this testimony, OIG recommended that CMS require states to use claims level methods, and also suggested that to the extent that CMS doesn't have the authority to do that, Congress should consider making statutory changes to give CMS that authority. So that led us to a question, which is, what are states actually doing to prevent duplicate discounts? And to answer this, we conducted a 50-state survey that reviewed state laws, regulations, and sub-regulatory guidance, and also involved discussions with state policy makers in instances where we couldn't find definitive information on the topic, all with the goal of determining what states actually do to identify 340B drugs, both on the Medicaid side, the fee-for-service side and the managed care side, and both for covered entities and their contract pharmacies, so they can exclude them from their rebate request. And then separately, just as part of this survey, we also looked at how state Medicaid programs reimburse 340B covered entities and their contract pharmacies for both 340B and non-340B drugs. So the survey contains detailed information on each individual state, and it's available to subscribers to Manat Insights, which is our subscription content service. It is over 300 pages long, and summarizing it in this webinar was not an option, but we did end up with some interesting high-level takeaways from the survey itself. So first, with respect to what states do to identify 340B drugs that are billed directly to the Medicaid program by covered entities, 12 of them rely solely on the Medicaid exclusion file. 22 of them rely solely on claims level identifiers, and some states use both. One state is South Dakota, actually prohibits covered entities from using 340B drugs for Medicaid beneficiaries at all. And another state, New Hampshire, permits 340B drugs to be used for family planning clinics by family planning clinics only. On the managed care side, obviously a number of states don't have a managed care model in Medicaid, or even if they do, they carve the pharmacy benefit out of Medicaid managed care. But of those who do pay for drugs through Medicaid managed care, some of them require MCOs to use the same mechanism as the Medicaid fee-for-service program, which, as I mentioned earlier, can potentially be problematic if that mechanism is the Medicaid exclusion file, since that was really designed for fee-for-service, not for managed care. Other states require managed care organizations to have a methodology to identify 340B drug claims, but they don't specify what that methodology should be. And then still other states just don't have any policies on this at all, or they advise covered entities to contact managed care organizations directly to make sure that there's a mechanism in place to accomplish this, but there's no state level mandate or requirement or anything along those lines. On the contract pharmacy side, and this I think was the most surprising piece of the finding to come out of the survey, almost 2/3 of state Medicaid programs prohibit 340B contract pharmacy arrangements on the Medicaid side completely. I mean, this is presumably a recognition of how challenging it can be to identify 340B drugs in the contract pharmacy context, for the reasons that I touched on earlier, that oftentimes you just don't know at the point of sale whether a drug is ultimately going to be 340B eligible. In those states that do permit Medicaid contract pharmacies, 340B contract pharmacies, they use different approaches to identify 340B claims. Some of them require claims level identifiers, which again can be a challenge because of the point of sale issues. One state requires contract pharmacies to use a separate NPI to bill 340B drugs and exclude all drugs that are billed under that NPI from rebate requests. And another state requires both covered entities and contract pharmacies to use a different provider number when they bill for 340B drugs. Again, this doesn't, on the contract pharmacy side, none of these approaches really address the point of sale issue. Finally, as I mentioned earlier, our survey also looked at how state Medicaid programs reimburse both 340B and non-340B drugs. So as I mentioned earlier, when a covered entity uses 340B drugs to Medicaid patients, it has to bill the Medicaid program for those drugs at its actual acquisition cost, so that the Medicaid program, since it's foregoing a Medicaid rebate for those drugs, instead gets the benefit of 340B pricing. That's actually a fairly recent federal mandate. And our survey found that most states have implemented that mandate and are reimbursing at actual acquisition costs for 340B drugs on the fee-for-service side. We did see, however, that there's significant variation among how state Medicaid programs reimburse for non-340B drugs. We also looked at, just to get a sort of a complete picture of the reimbursement question, we also looked at the dispensing fees that state Medicaid programs pay for 340B drugs. And there's some variation. The lowest was just over $2 per prescription. The highest was just over $21 per prescription. The majority of states set dispensing fees at between $10 and $11 per prescription, which is a lot more uniform than we had actually anticipated. And again, detailed information for each state is available in our full survey, which is available to those of you who are subscribers to Manat Insights. Okay, so the last area of discussion before we turn to questions is sort of looking forward, the future of the 340B program. Given the increasing concerns about and focus on the accuracy of provider-level methods to identify 340B purchased drugs that are billed to Medicaid, I think that there's going to be continued movement by state Medicaid programs of their own accord to use claims-level methods, and presumably continued focus by the Office of Inspector General on this shift as well, which ultimately may well result in congressional action to give CMS the authority to require claims-level identifiers. I also think that there's going to be additional focus on oversight of the 340B program, including potential congressional action. Over the past several congressional sessions, there have been a number of pieces of legislation introduced that would have made changes to the program. None of them were actually enacted, but they really spanned a whole range of different issues. One legislative proposal would have established an actual statutory definition of who constitutes an eligible patient for 340B purposes. And unsurprisingly, that definition would have been significantly less open-ended than the current one that OPA promulgated back in 1996. There was a proposal to impose a moratorium on new contract pharmacy arrangements, precipitated by the concern that it's difficult to identify and avoid duplicate discounts in the contract pharmacy context. There was a broader one that just would have required HRSA to promulgate regulations on reducing duplicate discount risks. And then there were proposals that really just kind of dealt with transparency, requiring hospitals that participate in the 340B program to provide information on the costs they incur for charity care, requiring hospitals that participate in the 340B program to provide information on the payer mix of the patients that they provide 340B drugs to, what percent are uninsured, what percent are Medicaid, what percent are Medicare, what percent are commercially insured. There were also proposals to require covered entities to establish a sliding fee scale for drugs for low-income or uninsured patients. There was a proposal to implement a moratorium on participation of new covered entities in the 340B program, while some of the potential issues of the program are resolved. So like a real range of legislative suggestions, none of which, however, actually came to pass. And then lastly, of course, the future of the 340B program is deeply intertwined with the larger discussion on drug pricing, drug importation, et cetera. And as part of that discussion, there's also been questions as to whether, if there is significant federal change in the drug pricing arena, the 340B program in its current incarnation even needs to continue to exist. So with that, we can move on to questions. But before we do that, let me give you the second CLE code, which is LTK 612. That's Lima Tango Kilo 612. So if you just give me a minute to take a look at some of these questions and start to hopefully be able to give you some answers.
Yeah, that was a great presentation, Helen. Lots of good information, and thanks to everybody that participated in our polls. It was nice to see that level of participation. Now, just as a reminder, throughout the presentation segment of the webinar, we've all heard and seen a lot of great information, but we've really, there's so much more out there. We've only scratched the surface. So make sure that you send in your questions now if you want Helen to go into greater depth on any of the issues that were presented. This is always a popular segment of our web seminars, and we have a lot of outstanding questions. If you have not submitted your question yet, do so now, and just use the control panel tool, and we'll get to as many as we can with the time we have remaining. So let's get to it, shall we? Helen, start tackling the questions.
Yeah, sure. I'll start with a very straightforward one. You mentioned covered entities and covered entity child sites. What's the difference? So as I think I referenced, the Office of Pharmacy Affairs maintains a database that lists all of the covered entities that have registered to participate in the 340B program. In order to participate, you don't have to just fit within one of the eligible categories. You've actually got to register with the Office of Pharmacy Affairs, and you have to register not just the main facility, but also any off-site outpatient facilities that also participate in 340B, and those are referred to as child sites. So it's sort of a term of art used in the 340B program. Let's see. Okay, another question here. Do managed care organizations and/or PBMs typically realize a spread in 340B, or are they treated as pass-throughs? So that's also, like everything else that I seem to have mentioned so far, been a bit of controversy. In some instances, plans have been, including Medicare, including Medicaid managed care plans, have been trying to negotiate with covered entities reduced reimbursement rates for drugs that are purchased by the covered entities under the 340B program. And there are different schools of thought as to whether that should be permitted. It is not illegal in any way. It's not prohibited in any way, shape, or form. I think the covered entities position would be that the purpose of the 340B program was to enable them to stretch scarce federal resources as the sort of like memo in support accompanying the legislation said, to serve patients they might otherwise not be able to serve, and that the purpose of the program is not to allow payers to share in a portion of the savings. But again, it does happen, and it is not prohibited. So the short answer is yes, but that's an area that I could also see potentially at some point being subject to some sort of congressional action. Okay, let's see. So this is a good question. So for states that have pharmacy covered through Medicaid managed care, what are typical methodologies utilized to incorporate 340B drugs into the managed care rates? The answer is there really is nothing typical. I think some states they've tried to address that or take some steps toward that. In some states, they haven't really focused on it at all. I think this is also an area that perhaps states will start to focus on in the future, but it's always been a bit surprising to me that there hasn't been a more uniform sort of approach toward addressing that very question. So let's see, what else do we have here?
Some of these are not short questions, so I think it takes Helen a little bit of time to read through them.
Okay, so how long does it take a contract pharmacy to determine a particular transaction is 340B? It really depends. In the past, like going back a few years before the real advent of 340B third-party administrators, what often happened was that a covered entity patient would get a card or some sort of other like a discount card or something that they could bring with them to the pharmacy, especially in the case of an uninsured patient. And presenting that card, the pharmacy would know that it was a 340B eligible patient and would know immediately that the patient was eligible for 340B drugs. Now, I think in some instances, there are third-party administrators that, like I said, sort of gather the data from the pharmacy and data from the covered entity, and pretty much almost instantaneously or close to it, are able to determine whether it's a 340B drug. So it really kind of depends on the technology that the covered entity and its contract pharmacy and administrator put into place. Let's see. Are there any regulations prohibiting claims for 340B purchased drugs to also be submitted for commercial rebates? I am not aware of any such regulations. No, not to my knowledge. Are you familiar with the Oregon model of retroactively identifying 340B managed care claims on a quarterly basis? If so, what are your thoughts on this potentially becoming a model for more states to use in place of modifiers? So yeah, so I am familiar with that because that's one of the things that we looked at as part of our survey. And, you know, it's interesting. I think that potentially could be a good model for other states. The devil's in the details, of course, but it's certainly, I mean, Oregon has been ahead of a number of other states in really trying to sort of practically address this. And I think the model is certainly an interesting alternative to the more standard approaches that other states are using. What is the one state that requires a different MPI number for 340B claims? You know, I don't remember off the top of my head, but I have your name, so I can get back to you on that and let you know the answer to that question. Did we get survey responses for all states? Yes, we did. well, let me say that differently. We did research on laws, regulations, guidance. We did outreach to state officials, either the Medicaid program or the pharmacy program. We put together our survey results, and then to make sure that we were accurate, we sent those surveys back to each individual state to have them review it and sign off on it or provide comments for it. And we got feedback from over 2/3 of the state, either saying, yes, this is right, or giving us a few changes. So the states were really remarkably cooperative in helping us put this together. I think we do have, Manat has a pretty extensive connections with different state Medicaid programs, so that helped. We had some folks sort of pull their, call personal contacts, but yeah, no, the states were pretty cooperative about this. Let's see. You mentioned a federal mandate to require submission of the acquisition cost. Please explain, provide citation for this mandate. This is apply to fee-for-service and managed care. It applies to fee-for-service. I believe it was in a state Medicaid director letter, but I would have to go back and check exactly what the source of that was. Let's see. There's some that I'm just going to skip that I just don't have the answer to. So let's see. Yeah, what type of dispensing fee and PBM admin fees are common in Medicaid managed care? All over the map. I don't think there's any. Yeah, I was sort of surprised. I was sort of surprised to see how uniform the Medicaid fee-for-service dispensing fees to contract pharmacies or to 340B covered entities or for 340B drugs were, because I've seen a much more disparate set of fees in the in other contexts. So there really is no. I wouldn't say there's anything that's really common. It's sort of all over the place. Doesn't OPA require that contract pharmacies can only act as retail pharmacy when dispensing to Medicaid patients? I'm not quite sure what that means, but I would ask the commentator to feel free to reach out to me via email. I'd be happy to explore that further. We talked about that.
Yeah, I know some of these questions really put you on the spot, Helen. You're probably going to have to go back and do some research on these and follow up with some of the people. I'm looking at some of these and thinking, you can't possibly know all of these off the top of your head, but you've been doing a great job so far. So if you want to do more, we can do more. But if you want to start closing it down, we can do that too now.
Let me just finish reading through the questions and see if there's, a lot of them would just require a lot more information or some back and forth. Like I wouldn't be able to answer them without more context. So. Any thoughts or comments on states moving to unified Medicaid drug lists and forcing managed care companies to adhere for savings at state level? I will be honest, I have plenty of thoughts on that, but I don't think it would be diplomatic of me to go into that in a public forum. So I'm going to pass on that one. And I think that's it. So I hope that this was helpful. Like I said, I'd be happy to entertain follow-up questions if anybody has any, and I'll turn it back over to you, Dan.
Thanks, Helen. And why don't you go to that last slide so people can see your contact information if they do want to follow up with you, because I know that you'd love to hear from people and start a dialogue and talk about this in greater detail. So I hope everyone enjoyed this event and have taken away some new insights. And remember, if any of your colleagues missed this presentation, once again, it will be available as a recorded archive as early as tomorrow. So by the end of this week for sure. And you'll get an email with the link that will take you directly to that recording. I'd like to once again thank our friends at Manat for partnering with us on a great event. And I'd also like to encourage you to look for future web seminars by visiting pharmavoice.com. Helen, do you have any final thoughts?
just thank you all very much for coming.
Outstanding. Well, thank you everybody for your time and enjoy the rest of your day. The event is now over.